All right, let's get straight into it. If you're prepping for your GP AKT exam, you're going to want to pay close attention. The UK has just dropped brand new Unified Asthma Guidelines, and they're a game changer for how you'll diagnose and manage patients. We're going to break down exactly what you need to know nice and quick. So first things first, this is not just some minor tweak. For the very first time, all the big players, BTS, SIGME, and NICE, have come together to create a single unified guideline. What does that mean for you? It means for your exam and for your day-to-day practice, this is now the one and only gold standard. No more confusion. So here's our plan. We'll start with the massive shift in how we diagnose asthma. Then we'll walk through the brand new treatment pathways for adults and for kids, talk a little bit about monitoring, and then we'll wrap it all up with a super high-yield summary of the absolute key facts you need to nail for your exam. Okay, if you take away only one thing, let it be this. A diagnosis of asthma now requires both a story that fits and a positive objective test. You just can't rely on symptoms alone anymore. It's not enough. Until you have that proof, the official coding is suspected asthma. So let's picture an AKT question, right? An adult comes in, classic story, wheeze, cough at night. You're thinking asthma. According to these new guidelines, what is the very first objective test you reach for? The new pathway's really strict. It's sequential. Step 1 is all about looking for that type 2 allergic type inflammation that drives so much asthma. You do that with either a FeNO test or just a blood eosinophil count. If it's positive, boom, you've got your diagnosis. If not, you move on to step 2, bronchodilator reversibility. Still nothing? Then you go to step 3, checking peak flow variability. You've got to know this step-by-step process. And here is a number you absolutely have to memorize. For adults, that phenodiagnostic threshold is 50 parts per billion or more. A positive result is a really strong sign you're dealing with asthma. This is classic exam fodder. Okay, so that's adults. Now let's switch gears to kids, another classic scenario. How does this whole diagnostic algorithm change when you have a child, say between 5 and 16, sitting in front of you? Well, for kids, it also starts with FeNO as step 1. If that comes back negative, you move on to bronchodilator reversibility at step 2. But here's the key difference. If you're still not sure after checking peak flow variability in step 3, look at step 4. Now you're actively looking for atopy with skin prick testing or IgE levels. That's a really key distinction from the adult pathway. And here we go, the second number you just have to know for your AKT. For kids aged 5 to 16, the FeNO threshold is lower. It's 35 parts per billion. So remember, 50 for adults, 35 for children. Do not get those mixed up. Okay, let's move on from diagnosis to management. For everyone age 12 and up, the guideline ushers in a totally new way of thinking about treatment. It's all built around one core idea. We have to stop relying on those blue rescue inhalers. This right here is probably the most practice-changing line in the entire document. Prescribing a short-acting beta-2 agonist, a SABA like salbutamol, all by itself is no longer recommended. The evidence is clear, it's linked to worse outcomes, even a higher risk of mortality. So the new rule is every single asthma patient must be on an inhaled corticosteroid. Now, the new pathway is built on two key ideas that both use the same combination inhaler. First, you have air therapy. That means using an ICS/formoterol inhaler only when you need it for symptoms. Second, you have MART. That's using the exact same inhaler, but now you're taking it every day for maintenance and using it as your reliever. Getting this difference is absolutely crucial. So, this new treatment ladder for anyone over 12 starts at step 1 with as-needed AIR therapy. Simple. If that isn't cutting it, you don't add a separate blue inhaler. Nope. Instead, you just move to step 2, which is using that same inhaler on a regular schedule as low-dose MART. See, it's a really simple, elegant system. Now, for kids between 5 and 11, the approach is a bit different. The guideline is really practical here. It recognizes that the MART regimen might be tricky for some kids in this age group, so it actually gives us 2 different pathways to choose from. The starting point for kids is more traditional. For a newly diagnosed child, you'll start with a regular, twice-a-day, low-dose inhaled corticosteroid, and you give them a separate SABA for when they get symptoms. This is a big difference from the adult pathway, which you'll remember starts with as-needed air therapy. So when it's time to step up their treatment, you come to a fork in the road. As you can see here, on the left, if the child and their family can handle the regimen, you move them on to the pediatric MART pathway. If they can't, you follow the conventional pathway on the right, which involves adding in other drugs like an LTR. The choice really comes down to what's practical for the patient. And just a quick word on the under fives. We all know diagnosis in this group is notoriously tough, so the approach here is really pragmatic. For a child with pretty significant symptoms, you offer an 8 to 12-week trial of a low-dose ICS and just see what happens. Of course, great asthma care doesn't just stop once you've started a treatment. It's a continuous cycle, right? You're always monitoring how things are going and, just as importantly, knowing when it's safe to step treatment back down. At every single review, you're checking for those key signs of poor control. But look at this. This is a huge change. The guideline now explicitly says you should not be using regular peak flow monitoring for routine assessment anymore. Instead, for adults, they suggest you might want to check a FeNO level before you decide to change their therapy. And remember, the treatment ladder isn't a one-way street. Once a patient has been doing really well, nice and controlled for at least 3 months, you should be actively talking about stepping their therapy down. This is a huge part of patient-centered care, and it's something to think about at every annual review. Whew, okay, we have covered a lot of ground. So let's boil it all down to the absolute must-know facts for your AKT. This is the stuff you really need to have locked in. For diagnosis, you've got to remember, history plus an objective test is now mandatory. Memorize those FeNO cutoffs, 50 for adults, 35 for kids. And if you don't have that objective test, it's only suspected asthma. And for management, the big, bold headline is no SABA-only treatment, period. For anyone over 12, the pathway is AIR, then MART. For children aged 5 to 11, you start with a regular ICS, and then you step up to MART only if they can manage it. So we'll leave it with this thought. The next time a patient walks into your clinic with a wheeze, these guidelines have totally changed the conversation. The question isn't just what are your symptoms anymore. The question is now, what is our first objective test? Getting that right is the new foundation of great asthma care.